Okay, let's talk about hernias. And when we talk about hernias, it results from a weakened abdominal muscle, and parts of the bowel can protrude through that weakened abdominal muscle. So they can be described as reducible, meaning you see a hernia, you palpate it, and it goes back in, okay? It pops back out when you stop palpating it. Or it could be irreducible, and that another term for that is incarcerated. It means you cannot push it in. You cannot put it back to place. That needs to be seen by a surgeon because they may be at risk for obstruction or bowel perforation. Okay. Risk factors include being a male, and especially with a male, you're worried about this indirect inguinal hernia that can slip down into their scrotum. Older adults, because all your muscles get weak as you age. People with increased intra-abdominal pressure are going to be at risk as well. So this is obese people and people like pregnancy. Okay, they're going to have increased intra-abdominal pressure, so they could be at risk. Um, Incisional hernias can happen after surgery due to things like malnutrition because the wound doesn't heal properly, or from being obese, or maybe there's an infection in the surgical incision. So that's another way hernias can manifest. Now, a hernia can become strangulated, which means the blood supply is completely cut off to the bowel in that area, and it can become necrotic. So you got to jump on that quick because they're going to need surgery. The patient will have the strangulated hernia. They'll be tachycardic, have abdominal distension. This can result in an intestinal obstruction, so they could be vomiting, fecal odor, vomitus. Okay, so that's like a little clue. If somebody has a fecal odor, vomitus, they may have an obstruction. They're going to have a fever, and this could result in necrosis, obstruction, or perforation. So you need to act on it quick. And students get strangulated hernia confused with irreducible. They're two separate things, okay? So make sure you know the difference between them. Okay, hernia treatment involves non-surgical and surgical. So for non-surgical, you would have patients wear a truss. And this is a picture of a truss that basically holds the hernia in place, like pushes it back in. Surgical, I love these patients because they were super easy. It's a fast operation. It's a fast recovery when I worked in the recovery room. But after, I would have to teach them no coughing or straining after they have that kind of surgery. But it was really easy to take care of them. Now, irritable bowel syndrome is a syndrome where the cause is really uncertain, meaning functionally there's nothing wrong with the bowel, but yet people that have it complain of cramping, abdominal pain, bloating, and they alternate periods of like constipation with diarrhea, um, and it can be quite uncomfortable. So dairy, caffeine, alcohol, stress, anxiety, and depression may have a factor in IBS, irritable bowel syndrome. So patients would be taught to limit these factors. Constipation, you would teach the patient to exercise, increase fluids 2-3 liters a day. Everybody should be eating 30 to 40 grams of fiber a day to add bulk to your diet. And then always try to move your bowels at the same time every day. And if some help is needed, we always go bulk forming medications first, then a stool softener, then stimulant laxatives and enemas. There's also medication for IBS specific that increases fluid secretion in the intestine to promote motility, and it's called lubiprostone. Okay, if somebody has bouts of diarrhea, there are medications they can take. So loperamide is a medication you can take for diarrhea. Psyllium is bulk forming, and that can help with diarrhea in certain cases. Allosteron, that helps firm up the stool, so they can take that as well. Also, they should be taught to start eating whatever food is giving them the diarrhea if they know what it is. Okay, now we're going to talk about intestinal obstruction. And there's two basic types. There's a mechanical intestinal obstruction and a non-mechanical. And I'm going to talk about mechanical right now. A mechanical intestinal obstruction means something has actually caused the intestinal obstruction. And they're going to need surgery, and you need to be able to identify it fast so that their bowel doesn't perforate. So it can happen from postoperative adhesions, if you look at this picture, cancer, like colon cancer, a hernia, intersuspension, which you're going to learn about in pediatrics, and a volvus. That's when the bowel turns on itself. So all those kind of things can cause an acute intestinal obstruction. What happens with the intestinal obstruction is you have the obstruction and there's going to be no passage of stool or gas, and that's called obstipation, and that's going to be proximal to the obstruction. Then there's going to be increased contraction in the proximal part, and they're going to have borborygmi. So they're going to have high-pitched tinkling sound in one area of the abdomen, and below it, they'll have hypoactive bowel sounds below the obstruction. That's how you know one of the signs of having an intestinal obstruction. Then what's going to happen in time, there's going to be dilation because the gas is increasing inside the bowel, and there'll be compression, and then necroses, and then finally, if they do perf, they're going to get peritonitis. So for peritonitis, be looking for a high fever, high white count, rigid board-like abdomen, and they'll be guarding. The abdomen is going to be really tender. And then they'll get shock and die if you don't recognize it early. So it's really important to recognize the intestinal obstruction early. The other thing about intestinal obstructions, never, ever, ever give anybody a laxative that you think has an intestinal obstruction because they could perforate. Nursing care involved in peritonitis includes putting the patient in Fowler's or semi-Fowler's position. This helps with lung expansion, and it also helps to drain the peritoneal fluid down. They most likely will have an NG tube, whether it's pre-op or post-op, so you're going to monitor and maintain the NG tube, and you've had NG tube care before. Keep the patient NPO if you think they might have peritonitis until the surgeon can see them. And then they'll still be kept at NPO if they have peritonitis. Monitor for hypovolemia, monitor for septic shock, and fluid and electrolyte imbalances. That's also important to do. Okay, non-mechanical intestinal obstruction means there's an obstruction. Really what it's referring to is that there's no peristalsis. In other words, the bowel is intact. It doesn't have any deficits except it's not moving. There's no peristalsis. So this could happen after surgery due to a paralytic ileus. It could happen because hypokalemia can slow the bowel down. And then if there's an emboli in the mesenteric, like an emboli shoots there, they can have a non-mechanical intestinal obstruction, and peritonitis can also cause that. So with paralytic ileus, you will not have bowel sounds. And the way to get the bowels kind of moving, if they had surgery, is we encourage them to ambulate to promote flatus. Flatus is the gold standard that peristalsis has returned. So that's what flatus means. And everybody gets happy when patients fart after surgery. There are some differences in the assessment findings between a small bowel obstruction versus a large bowel obstruction. So for small bowel, the small bowel is mostly responsible for helping us absorb fluids and electrolytes. So there's going to be a severe fluid and electrolyte imbalance. In fact, people can sequester like 5 liters of fluid in their small bowel, which is going to give them a relative hypovolemic shock. So look for the tachycardia, the tachypnea, the low blood pressure, the narrow pulse pressure. They could have fecal smelling vomitus, that might be a clue, and projectile vomiting. They are going to have metabolic alkalosis, especially if they have an NG tube, because from the pylorus up, If they're like vomiting, they're losing acid, so their ABG will be metabolic alkalosis because of the loss of acid. They could have visible peristaltic waves in the upper abdominal cavity, and they can have epigastric and upper abdominal distension. Now, when we talk about the large bowel, they just have minor fluid and electrolyte imbalances. They're going to have metabolic acidosis, and they'll have lower abdominal distension, abdominal cramping, and that's going to be intermittent and infrequent vomiting. They may have diarrhea, or they may have ribbon stools if they have an impaction. So those are the differences between a small bowel and a large bowel obstruction. The labs you would expect or anticipate in a client with intestinal obstruction include a high H&H. That's due to hemoconcentration because they're dehydrated, as well as a high BUN and creatinine for the same reasons. If somebody had a strangulated hernia or if they had a perforation, you might see an increased WBC. They could be developing peritonitis, so keep that in mind. Look for that board-like rigid abdomen. They will have decreased sodium, chloride, and potassium levels. Patients with intestinal obstructions need to be kept NPO, whether they're pre-op or post-op. You're going to put them in semi-Fowler's position because this helps drain peritoneal fluid. You're going to assess bowel sounds. You're going to probably, most likely, put in an NG tube for somebody with a mechanical intestinal obstruction. You may do it for somebody that has a paralytic ileus or a non-mechanical intestinal obstruction if they become nauseous and start vomiting. Manage pain, especially after surgery. Encourage ambulation after surgery because ambulation helps get the bowels moving again. Inflatus indicates that peristalsis has returned, so there's been a resolution of the intestinal obstruction when it's non-mechanical if the patient has flatus. Okay, I'm going to talk about nasogastric tubes right now. It seems fitting. The nasogastric tube procedure and caring and assessing for placement and patency is on 4 different proctors. And the reason for that is that the nasogastric tube is a fairly common therapeutic procedure performed by nurses with the doctor's order. But it also has a lot of complications associated with it. So it's really important you know how to insert and remove and care for an NG tube. So this NG tube here is called a Salem stump. If you notice, it's got a blue pigtail. That's an air vent. And it's vented so that the end of the nasogastric tube doesn't get stuck on the gastric wall and start suctioning the gastric wall, okay? Because that could cause injury. So it's probably going to be called a vented tube on your proctor, and you may have to pick out what type of tube you're going to grab. So just remember the blue pigtail, and on top of that blue pigtail, there's a vent. Remember, blue goes to blue because that's a separate piece, and that was invented probably 20 years ago or so. But we didn't always have that, and it would leak if you didn't keep it above the waist. Okay, so always keep that pigtail above the waist. Don't infuse, don't irrigate through it, and don't clamp it. Okay, because you need that air vent to prevent injury to the gastric mucosa. Now, make sure you understand the reason your patient is getting a nasogastric tube. Are they going to be fed, or are they getting it for gastric and intestinal decompression? Okay, so that could be used for somebody with distension and intestinal obstruction. You want to assess the placement and patency. So first off, when you are going to put one in, you have to know how to measure it. So measure it from the tip of the nose to the ear to the xiphoid process. So put a piece of tape around the tube so you know when to stop when you put it in. When you put it in, remember the head has to go a little bit forward, not backwards, because you'll put it into the lungs if it goes backwards, if you put the head backwards. After you get it in,
check the mouth because it could be coiled in the mouth, especially if it was really easy to place. Um, you definitely have to get a chest x-ray to determine the placement. You can aspirate gastric fluid and it should be low, like a pH of 1 to 4, but the gold standard is always going to be a chest x-ray. All right. So you want to assess the patency and placement every time you're going to manipulate it, anytime you're going to irrigate it. Okay. So to assess the placement after you get the chest x-ray, you're going to make sure you have the centimeters it's at documented so you can check and make sure it hasn't moved from that centimeter mark. So, like in other words, it'll say nasogastric tube in left nair at 52 centimeters. So when you come on shift, you have to make sure it's 52 centimeters. You need to irrigate it with 30 mLs normal saline Q4 hours. Okay, document INO. Obviously, if your patient has needs it for decompression, it's going to be hooked up to intermittent suction. If they need it for tube feeds, they're not, you still can irrigate it. And some of the feeding pumps come with irrigation. And if they have a tube feed, you can probably use tap water. But with somebody that is having suction, it needs to be normal saline. You're going to put the patient in semi-followers. Make sure the tube is fastened to the gown, not the pillow, not the bed sheets. Oral care needs to be given every 2 hours, and you need to monitor the nairs to make sure they're not having skin breakdown. When you're going to remove the NG tube, make sure you check the order, obviously. You're going to wear gloves, explain the procedure to the patient. If they're getting fed, turn off the feeding pump and disconnect it from the tubing. Otherwise, you're going to have a huge mess on your hands. Flush the tube with 30 mLs of air to clear the tube of fluid before you remove it. Obviously, you're going to, if it's adhered to the nose, you're going to take the tape off so you're ready to go and remove it. So that's removing the anchoring device. Give the patient facial tissues and put a towel or a chalk across their chest. Have the patient take and hold a deep breath. That's when you're going to pull it out. Now, you need to kink or clamp the tubing when you pull it out in case there's any fluid left in it because they'll aspirate that if you don't. Then throw it away, do hand hygiene, and allow the patient to perform mouth care.